You're listening to Medscape's In Discussion series on lung cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jacob Sands, instructor of medicine at Harvard Medical School and physician at the Thoracic Oncology Program at the Dana-Farber Cancer Institute in Boston, Massachusetts. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
I'm Dr. Jacob Sands, thoracic medical oncologist at the Dana-Farber Cancer Institute. Welcome to Medscape's In Discussion series on lung cancer. Today we'll be discussing disparities in lung cancer diagnosis and treatment. But first, let me introduce my guest, Dr. Narjust Florez, Associate Director of the Cancer Care Equity Program, a thoracic medical oncologist at the Dana-Farber Cancer Institute, and a member of the faculty at Harvard Medical School, as well as being the new Associate Editor of JAMA Oncology. Dr. Florez, welcome to In Discussion.
Thank you, Dr. Sands, for the invitation.
Dr. Florez, I would love to start out with a bit about your personal journey. What was your career path in getting to this point of being a lung cancer specialist?
So I'm originally from Venezuela. So the turmoil, political and economic of Venezuela took me out of the country to the Dominican Republic, where I finished medical school. Through medical school, I was offered the opportunity to do rotations in the United States. And during that time, I realized that my goal and my calling was to be a physician scientist. So I decided to do training at Rutgers, New Jersey Medical School in internal medicine. Through that time, I did a lot of research, but what I noticed is that most vulnerable patients were often excluded for studies and their needs were not documented. So my journey to cancer health disparities started during residency when I studied gastric cancer in Hispanics. Then I matched and fellowship at Mayo Clinic. This is another landmark moment. So moving to the Mayo Clinic meant that I was going to be in a less diverse population. I would still continue my work in cancer health disparities, but I was looking for that disease type we in oncology that fulfill the clinical part and the research part of a career in academia. So I was being modeled to be an agnostic phase 1 researcher. But a patient changed all of that. And that was a young patient with lung cancer that asked me many times not to tell her family about her diagnosis due to the stigma associated with the disease. So that was my calling. I need to treat younger women with lung cancer and to describe the disparities not only to this population, but all vulnerable patients with lung cancer.
Well, that's a great starting point. And so maybe before I get into some of the specific questions that I've had for you in discussing this stigma, because I think that is relevant, can you dive into a little bit more about the stigma specifically and patient experience around that?
So lung cancer, compared to any other cancers, has a high level of stigma because it's associated with smoking. Smoking is found to be a choice or a behavior when in fact is an addiction. So these are patients that disclose the diagnosis to a family member, to a primary care doctor, and the first question they get is, did you smoke? When a patient with colorectal cancer gets to disclose the diagnosis, nobody asks them, do you eat red meat? Because that is associated with colorectal cancer. So a lot of patients face a lot of stigma and a lot of guilt. That is not only internal guilt, but also by family members, by providers, that you have cancer because you smoke. And that makes many of these patients don't want to disclose their diagnosis. Compared to patients with breast cancer, many patients with lung cancer keep the diagnosis with themselves. And that breaks my heart because you are dealing with a disease, a fatal disease, and you are not seeking the support just because of the stigma associated with it.
Yeah. And to that point, I've had patients where they told family friends that they had breast cancer instead of lung cancer, just so that they wouldn't face some of that, I'll say, backlash that is quite quite common. I think it's an important part of treating patients with lung cancer is being very aware of that. And anytime I'm asking people their smoking history, which of course is really important to some of the decisions that we make around their care, I'm always very attentive to how patients are taking that and trying to shape that discussion in a way where I say to them, hey, this is the past. We're going to move forward from here. It doesn't necessarily matter at this point how we got here, but this is relevant to some of the decisions we're making and really making every effort I can to help relieve them of some of that internal difficulty around that prior history. It's such a challenging topic. And now I'm going to transition the discussion a bit, though. We're going to focus specifically on disparities and the impact around care. This is a little bit different than some of the discussions that we've had as part of this lung cancer series. That being said, this is really one of the most important topics, and thankfully something that I think there's increasing attention to, but that doesn't necessarily mean that that attention has really led to changes in the care, and I think that's what we really want to get to. So first of all, one of the most striking things that I've learned in the last few years is that the most important determinant of one's healthcare outcomes is the zip code within which they live. It's not their blood pressure. It's not a diagnosis of diabetes and these other things that would be more obvious. It's actually the zip code. Can you talk a little bit about that?
So to the listeners, social determinants of health are secondary to our environment, exposure, employment, and education. And what you said, Dr. Sands, is 100% true. For our patients with lung cancer, 80% of their outcome is not determined by clinical care. It's determined by the social determinants of health. Do they have access to food? Do they have access to transportation to make it to the cancer center? Do they have the health literacy to understand a clinical trial? I use this example very often, in which a patient can have a PD-L1 or 100%, but if the patient doesn't have transportation to the cancer center, your overall response rate is 0%. So how relevant is that PD-L1 or 100% if the patient cannot get therapy? Those aspects of having access to healthcare, being in a safe neighborhood, are sometimes more important than those genetic mutations that we talk about it so much.
Yeah, and you're outlining some of the kind of non-health system associated challenges. And I think this is part of why there's such difficulty in making real progress in reducing disparities, because it's such an overwhelming topic in some ways that there are threads in other aspects of society that are not specific to the healthcare system that I think sometimes make it more challenging in how to really make improvements. And we're going to dive a little bit into that, but I'd make the point that lung screening is probably the most important thing we can do that's cancer related. It is the number one intervention that could reduce cancer mortality. I'm talking all cancer mortality, but the fact that lung cancer represents about a fourth of all cancer related deaths, and lung screening has the potential to so significantly increase the early stage diagnosis and therefore lead to actual cure and improved outcomes. This really is the number one intervention. Now, this is something that unfortunately is broadly not being done. So I think there's a lot of improvement for all populations. But that being said, there has been an underrepresentation of minority populations, I think both in qualifying for lung screening as well as actually being offered lung screening. Can you dive into a bit of some of the challenges in recognition and enrollment to lung screening programs?
So there are two main issues with lung cancer screening. One is, and this is an example of intersectional identities. Women, which is 52% of the population, are significantly less likely to offer lung cancer screening, and that delays the diagnosis for a potential lung cancer. So these are patients that qualify for lung cancer screening. So if you're a woman, you are less likely to be offered the lung cancer screening. You are offered other more gender-specific screening that have less mortality. And then if you're a minority population, we talk about Black, African Americans, Hispanic, Latinx, or Native American, you're also less likely to be offered that by your primary care doctor. And there's 2 points here. One is that the intersection of identities is often forgotten in cancer health disparities. So if you're a woman of color, right, gender bias, racial bias, that's the group that is less likely significantly to be offered lung cancer screening. So this is an example of the intersection of these two vulnerable populations. In addition to that, Something that we also often forget about lung cancer screening is the possibilities of lumping them with other types of screening. So let me explain this. So this is done at UNC. It was started by Dr. Patricia Rivera, in which the woman gets for mammogram and you get them into lung cancer screening the same day. So there's a lot of interventions that have been developed, but we're still not doing it for most patients. And I think there are many factors that are affecting that, but the intersection and the lack of sometimes insurance is a very important negative factor for getting the adequate testing.
What does the mammography screening data show? Are we seeing the same disparities within mammography, for example, which tends to be, I think, one of the more commonly performed screening tests amongst populations that qualify?
So women of color are less likely to get mammogram. But when we talk about 6% in lung cancer screening and like 68% in breast cancer screening, we get to learn from the breast screening practices how to get to vulnerable populations. And one of that is the mammograms. We're often in the ivory tower. In order to improve things in the community means we need to come to the community. And I think we need to learn what the breast screening has done to get more women.
I suspect there are differences within geographic populations as well. And when we're talking about disparities, the rural disparities versus the populations that are living in cities, I'm sure there's a lot of similarities, but can you talk about these different geographic populations? Are there similarities? Are there specific challenges related to them?
So I have the benefit that I practice in Wisconsin and Minnesota. So I have a lot of patients for the rural U.S. There are disparities in both groups, but the disparities tend to be a little bit different. So the rural population in the United States have a lot of geographic distances. In some areas, the closest oncologist can be in 100 miles ratio. And if you know something about the Midwest, is the winters are no chill. There are a lot of snow, and that's taken into account. Also, a lot of farmers are uninsured, and it's a population that we forget. They're independent. They are their own boss. They don't work for a big company. So an insurance out of pocket is like a humongous amount of money. So the disparities are there, or farmers are often underinsured. There's geographic differences because there is not that many oncologists. In addition, there is delays in diagnosis because often those specialized services are not available. And then the patient has to wait 4, 8 weeks, 12 weeks in order to go somewhere. And the financial toxicity of going somewhere that we often forget. So driving from North Dakota to Mayo Clinic, that's a 5-hour drive. So that's very unique to the rural population. Lung cancer screening, going back, significantly less in rural U.S. In the city, still high levels uninsured, but you have different problems. Social determinants of health, your safety in your neighborhood. You can have an oncologist in 5 blocks, but if those 5 blocks are not safe, you need to find an alternative way to get to the cancer center.
Yeah. And one of the things that's been striking to me too, within the urban population, it might be, a 10-mile distance, but that can be the subway to 2 different bus lines. Sometimes it is surprising to me, the long journey that patients have to take to get into clinic, even when the distance isn't so far. It's actually quite a bit. And so for patients who are getting chemo to then have to take a bus transfer and such to get home, and the commute can be quite challenging.
Yeah, and don't forget that the pandemic is still here. So public transportation increases risk for these patients. And a lot of these patients at the beginning of the pandemic don't have no other way of transportation than public transport. And we need to ask, in order to address social determinants of health, we need to ask our patients about it. Particularly vulnerable populations are ashamed to share this information with the healthcare team. Like, I don't have enough food at my table. I lost my job. I don't feel safe in my house. The patients don't feel comfortable bringing it up. And it's our job to ask about their social determinants of health.
That's an excellent point. So you and I have talked before about some of the data around biomarker testing and the reduced amount of testing in minority populations. Also data around clinical trials enrollment. One thing that I think is commonly stated is that we need to be doing a better job of talking with vulnerable populations, that there's distrust, when in fact, We just need to ask them about enrolling. The data actually shows that minority populations are getting offered clinical trials at substantially lower rates. Not so much that they're refusing enrollment, they're just not being offered it. At the same time, there are significant differences in treatments being offered. So I'm kind of clumping this whole paradigm all together to just say that there are various time points within diagnosis and treatment where there is surprising differences in what's being offered and what's being done for these populations. Can you flesh that whole topic out a bit more?
So the main thing is that there are cancer health disparities and lung cancer from the moment of screening to the moment of death. They all have been documented at every stage of treatment. And these disparities are not only for racial minorities, also includes members of the LGBTQ community, incarcerated patients, rural patients, patients that are immigrants and no English speakers. That's a big chunk of the population that we're discriminated against it. And something that you mentioned, Dr. Sands, is mistrust. And I call the mistrust a mistrust challenge because there are historical events in which our patients may make reference to that. That doesn't mean they mistrust us. That means they know their history. Will you trust a healthcare system that continues to fail you, that continues to discriminate against you? So I have two things about mistrust. One, if a patient mentions some historical events like the Tuskegee experiment, I usually take responsibility as a healthcare worker and say, I'm sorry. Instead of saying, oh, that wasn't me, I wasn't born. No. That doesn't help build the relationship. I'm sorry. And the second thing about mistrust, we need to stop blaming or lack of representation and mistrust. So data shows that if a physician encounters a patient in which English is not the first language, they're less likely to offer a clinical trial. Data shows that there's also implicit bias, and implicit bias is ingrained and it's very hard. We need to address it every day. So there is an implicit bias that, oh, patients don't trust me, or patients don't trust the healthcare system, and this patient doesn't want to be part of a clinical trial. But that's not true. Data has shown that if you ask a Hispanic, Latinx, Black, African-American patient to be part of a cancer clinical trial, most of them agree to it. So let's eliminate that perception. We need to give our patients options. We are not here to make decisions for them. We continue to blame patients. Oh, the patient don't trust us. The patient doesn't do the lung cancer screening. The patient didn't advocate for biomarker testing. There are no healthcare providers. They don't know about biomarker testing, how they're going to advocate for something they don't know. So we need to remove the blame on the patient and take responsibility to create equity.
All right, so continuing that spectrum of the diagnosis to care, there's end-of-life data, actually, that's quite surprising as well, as far as differences in the number of patients that are really offered hospice and end-of-life care. Can you outline that a little bit more for us?
Yes, so there's two important disparities when it comes to the end or patient's journey. One of them comes from my own research, which is about palliative care for stage 4 lung cancer. Dr. Temal, many years ago, reported that patients with lung cancer stage 4 will live longer and better if we get the referral to palliative care. So we found that of 400,000 patients, Hispanic patients, only 2.2%, we didn't even make it 5%, were referred to palliative care. And these are all patients with lung cancer. So we're doing these very fancy studies and drugs for millions of dollars when we know that early palliative care prolongs survival. So that's one of the things. We are not referring minority patients to palliative care. One of the excuses is that, for example, Hispanics have a lot of fatalism. That is no reason not to refer to palliative care. We give patients option. And the second thing that you mentioned, and this data was presented at ASCO 2021, in which if a patient has Medicaid and metastatic lung cancer, they're most likely to go home without hospice. And how's that humane? Knowing that all hospice services are covered by Medicaid and they're all covered by Medicare. So these are patients with Medicaid. They're going home and dying without the support they need. And let's remember that hospice is not only good for the patient. It provides support to a family that's going to a very difficult time. So we're failing patients to refer to palliative care, and to even refer to hospice.
So we've covered a lot of ground on a number of disparities. You've discussed some of what we can do. And this is really the challenging thing. And I encourage our listeners to really be self-reflective in this, because I think there's a lot for us to learn. And I've recognized that there are a lot of kind of ingrained thoughts sometimes that are not really recognized. And I think there's a lot for us to self-reflect on in some of this. Now, some of it is self-reflection, and some of it is just actual changes to the system that need to happen. And so maybe let's start out with some of the changes to the system, and we'll get to that more personal kind of a look.
So Dr. Sands, you are completely correct. We need changes in the system level and the individual level from all providers. So the system level, the first thing that I advocate is for accountability. We need to make institutions and organizations accountable for disparities, because accountability means there are consequences to discriminating or excluding these patients. So one thing that is very important is we need to make sure that the trials include the patients that represent the used population. And that's needed by the FDA. Will you approve a drug that has been tested only in one group of patients, right? We need to make sure that approvals require that the drug is tested in a diverse population. As an associate editor, I'm learning a lot about this, and journals have a lot of power. Everybody wants to publish the study results. Okay, you're going to publish, but you need to break down your patients. What patients do you recruit? You need to break down tolerability and efficacy by race, gender, and age so we can learn. And you need to justify why you didn't have a population that represents the United States in your manuscript. It shouldn't be one sentence. It should be a whole paragraph to do that. And also, lastly, cancer centers should be accountable and responsible. One, for having clinical trials that are inclusive, and two, to have mechanisms to support patients during their journey. Because we often forget that the disparities only accumulate during cancer treatment. The financial toxicity, patients lose their job, they lose their insurance. So make sure we have systems in our cancer centers to support that. And lastly, let's stop charging for parking. Dr. Chino did a study in which a lot of cancer centers are charging for parking for patients, and that becomes a big burden. If you're getting radiation for limited stage, or you're getting radiation for a stage 3B, that's 35 treatments, that's 35 parking, right? And that's $30. That's a lot of money with somebody who has reduced income.
Those are excellent suggestions. And I think you're talking about systems level changes and pressures that really then individuals have to alter and come up with new ideas to be more inclusive in their populations based upon the pressures placed upon them. What else can be done for the individuals listening and they're thinking about how they can make their cancer centers more inclusive, or their clinics for those not in cancer centers? What are some more local kinds of things that can be done just as far as the flow within communities, or increased social work involvement, increased transportation assistance? I know can be important ones we've kind of touched on. Is there anything else to highlight in there?
I think having a diverse workforce is and will continue to be an intervention that has proven over and over again that helps reduce disparities. And we often focus on the physician workforce. It's diversity all through our providers, so medical assistants, clinical trial coordinators, right, or nurse practitioners. Having a diverse workforce have been proven to reduce disparities. So when you hire somebody, make sure you open all pools of candidates, because that we enrich the environment and we help close some of the existing gap.
And now to transition to maybe the harder part of this. So getting more into that self-reflection part, which I think is really a harder one, but also maybe the most important aspect in this. There are various occurrences that happen where, as a one-off story, maybe everything makes sense. But when really looking back at that experience, or what happened with an elderly Black woman as compared to a young white man, you recognize maybe there are differences in how someone was treated. This could be someone in the intensive care unit. One story I've heard is a patient in the intensive care unit who had come over from Haiti, and the way that this patient and his family were treated all seemed somewhat justifiable, but at the same time, there was actually another young white patient who had a somewhat similar scenario and was treated entirely differently. Now, as a one-off, sometimes these can be really hard to recognize because one person's actions or way of interacting with some of these patients can seem completely justified as a one-off story. But when really comparing and contrasting the way that different individuals were treated, there can be some real standouts on this. It's such a hard topic to discuss, and this requires listeners to really, I think, be very open to critiquing themselves and thinking about how interactions could have happened differently. This is a tough topic to talk on, but are you able to dive into that a little bit more?
So that's very important that you mentioned that, Dr. Sands, because a lot of my research, a lot of my interventions come to the individual level. We do require a systemic change, but we are far away. We're many years, if not decades from that. So we, as providers, have a lot of privilege and power to create equity. And what I recommend everybody, as you say, is self-reflection. Reflect in those difficult cases. Reflect what happened there and could have been different. And if you want to have a frame of where to start, I would recommend our listeners to look at the principles of cultural humility. And this is not only for patient care, but this is interactions for everyone. And the principle number one of cultural humility is this is a life-learned journey. And a lot of the difference in treatment that we see in race and gender are because of stereotypes and assumptions. You assume that a population doesn't want treatment. You assume that that patient had a different decision. No. Cultural humility suggests that this is a lifelong learning. So listening is the first thing we can do. And the second thing after listening is to intervene. So that is extremely important because you can create equity today. You don't have to wait for the system. We all have so much power. And I'm going to tell you a quick story. So I had a patient that was an osimertinib, and then we do the first set of scans, and I see a stable disease. And I'm like, okay, let's see how it goes. And I keep talking to her, asking her, and I'm mentioning my mistake so we can all be open that we all have room for improvement. Second scan, there is disease progression. And I'm like, okay, there is disease progression. Let me sequence to see what happens with this EGFR. I did later learn that she was taking the osimertinib every other day or every 2 days to expand her prescription because her copay was so high. Finally, I was able to get on the phone, find copayment assessment program, and then she went on the regular dose. She had a partial response 2 months later. So here, how important was this EGFR mutation in the drug? She was often taking 2 doses of osimertinib a week to expand the prescription. So that is a moment in which I learned that I need to ask my patients about copay, about other resources, and if they feel comfortable taking the pill. That patient is still alive, and the patient has 2 grandkids now. So that little thing, I created equity by making phone calls and getting her in an assistance program and just listening. I finally listened, and she's doing much better. So that is a little example of how you can create equity as an individual.
I thank you for this discussion. This is such a big and I think in many ways overwhelming topic, but is extremely important for each of us to really be mindful about and think of ways that we can improve in the way that we're interacting with patients as well as improving the system itself. I would like to thank our listeners for attending this discussion on disparities, as well as this entire series on lung cancer. This has been such a pleasure to be a part of. This is Dr. Jacob Sands for In Discussion.
Thanks for listening to Medscape's In Discussion Lung Cancer podcast series with our host, Dr. Jacob Sands. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on lung cancer.